let's get this fundamental problem. Like, why is it still so hard to implement AI in hospitals? Like and I agree with you, it seems like the solution, like the only solution that's going to solve many of these problems, but it just isn't happening. What are those barriers?
As we dug into the problem, starting the company, our working premise was that the AI models just weren't performant, right? Healthcare is super conservative. They really need tools to work perfectly before they could be adopted. And we always thought that might be the issue, is that AI is just not there yet. What we discovered was that AI is there. You have AI tools for virtually every common condition now. We've maybe not fully automated, but led to significant improvements in potential rates of diagnosis and treatment for these diseases. But it's the fundamentals of healthcare IT, the fact that we're working with legacy systems that are oftentimes decades old, multi-million-dollar support and maintenance that is already taking up all the hospital IT team's bandwidth. And the fact that these AI tools are these hyper-modern, cloud-based, data-hungry solutions that are being thrust into a very, very cautious, very legacy-driven, and very technically conservative environment. So to break that apart, I think you're talking about massive multi-million-dollar costs to turn on new vendors in healthcare, to move them through all the different committees and approvals and governance within a given health system. You're also talking about hyper-conservative policies around patient data and really a lack of comfort with both the cloud deployments that most AI vendors deploy within, as well as the data needs that those companies have. Fears around how is my patient data going to be used? If a vendor gets breached, as increasingly happens, what is going to happen to all the patient data I sent them? And then the last piece is really this patient safety issue of AI performance, where every single AI model, bar none, is biased, is going to discriminate, is going to underperform on some population, because no patient population is the same. And unlike drugs or devices, AI cannot just run a clinical trial, show it's performant, and then reliably work into the future. Right? AI shifts over time. These models are trained on certain populations, oftentimes those in Boston or New York and California, that do not resemble the average patient population that they're serving. And so these sorts of AI performance and governance issues around how are we ensuring the security of these deployments? How are we simplifying their deployments in ways that the average hospital's IT systems can digest? And ultimately, how do we actually ensure these tools are safe and governed for use in critical conditions like lung cancer or like stroke, where you do need to know that these tools are working reliably?
One of my questions, and I love this point about accuracy and validation, and I think it's one of the things I hear all the time about AI, right? Like AI changes, right? The models drift, they learn from things, there's bias. But at the same time, I always think, yes, but in the absence of using these models, what are we doing? We're relying on like an individual human's perception. Like, so how do you know what I mean? Like if a doctor, they see a patient, they become biased in their own way from the population that they're seeing, right? All of the error and omission things that you've experienced before can happen. And so how do we balance the idea that we're getting performance characteristics, let's say, or we're worried about bias in a model versus the fact that the entire world is biased about everything itself? Like how do we communicate that understanding to someone who might be, let's say, on the medical committee at a large institution?
Yeah, I feel like it's such a common question of, one, fear that AI is going to replace the doctor, combined with fear that the AI is not going to be good enough, going to hurt patients. It's kind of both sides of the spectrum end up being concerns that prevent adoption. That's a reality in healthcare. Unless you solve all the concerns for all the stakeholders, the default's going to be inaction. The analogy that I love to use is from the realm of medical errors, which is the Swiss cheese model, where if you are looking for medication errors, it is the role of the doctor, it is the role of the nurse, it is the role of the pharmacist. And on top of all those individuals whose job it is, you also have EHR alerts that need to be plugged in. But guess what? Medication errors post EHR is much lower than it was before, even with all those different layers that already existed. So technology is a completely orthogonal way to address and to start bridging some of these problems. And the thing with it is we're operating in an increasingly bankrupt healthcare system. And so we cannot afford to have more layers of Swiss cheese, more individuals. They're reviewing medical records, looking at images twice. The only way we can actually solve these things is with AI.
I mean, I couldn't agree with you more. It's like we don't have enough hospitals, we don't have enough doctors, we don't have enough nurses, we don't have enough, like, we just don't have the resources. And it's not like, we're going to magically build, 5 new hospitals here in the Bay Area, like next year, next month. It's just not going to happen. We're not going to put more, trainees through medical school, or we're not going to suddenly have a massive increase in the support and administrative staff. And so kind of what does that leave us with? It leaves us with AI. As you and Ferrum Health look at kind of your portfolio of partners that you work with, how do you think about this idea of performance characterization, right? And I assume because you have a number of different groups that you work with, you see, maybe not some as better or worse than others, but as being different, right? In one perspective to another, the bias issue there, everyone's going to have some flavor. How do you try to communicate those differences across your portfolio of partners?
In some senses, we actually stay out of the conversation. I think that there is a rapid expansion of AI models that are available. Individual use cases become increasingly competitive over time. And it really isn't the role of a governance platform that helps hospitals vet and deploy these solutions to also be the gatekeeper for them to try new solutions. The reality is that 80% of all models that are on the market perform significantly worse in the real world than they do in their FDA clearance. So the reality is most AI models do not work to the same degree that they claim to. So we're kind of living in a world where it's not really a question of how do you pick which AI model is the least bad. It's more how do you give hospitals the ability to look at all these tools where they know they're going to underperform in certain areas, but deploy them safely, knowing that underperformance. So maybe an AI model for fracture doesn't work well on pediatric patients. That's fine, but you need to know that upfront so that you can actually make the right decisions on where you are going to use it, where you aren't. So we think of AI as one, a governance process. So you need to have complete transparency and visibility into not just the technical performance of these tools. Are they running? Are they erroring out? Right? Are they taking forever to return? Matters, but much more important is clinical and business governance. Right? What are the impacts of these tools on populations? Are they biased? Do they result in downstream workflow impacts that are positive, driving productivity, or negative, slowing docs down? Those are the sorts of questions that actually cause the large majority of AI tools to not work or to cause patient harm. The second piece is the fact that AI is a life cycle. And so even when you know that a certain tool works, guess what? You're going to replace 20% of your AI solutions every single year as AI evolves. Half of the pilots that you launch on AI are just not going to be accepted by your clinicians. And so there's just an incredibly high failure and churn rate with these AI models that mean that if you're always spending $250,000, $300,000 to turn on every new solution, in a world where half don't work, in a world where 1 in 5 changes every year, you're dealing with just unsustainable technology costs. So AI governance is more of a lifestyle than it is a single solution, where I think hospital systems that are currently thinking of AI as point solutions and turning on a lung tool here and the breast tool here and a stroke tool here, they are solving point solution problems, but they're actually running into a very rapid quagmire of just multi-million-dollar AI support costs that rapidly ends up being the reason why they can no longer progress. And I think that's where most hospitals are today. They've tried AI, they've deployed 1 or 2 solutions, they've kind of run out of budget, and they're kind of sitting there to be like, okay, well, what do I do with the next 999 that are out there?
Yeah, it's interesting. I see and I hear hospital executives feeling kind of overwhelmed on the amount of choice, almost to the point where there's like an AI for everything, but we just don't know how to put that into place.